This is definitely not a kind of an academic talk. No. Actually, no. I didn't want it to be. This is definitely not a kind of an academic talk. No. Actually, no. I didn't want it to be. And actually, if you ask me, I'm just going to share my thoughts. It's not a talk. And then maybe one of the rare occasions when the speaker comes onto the stage almost half an hour before the scheduled time. Some other speakers don't even turn up. They come at 7:30, they come at 7:25 and all, something like that. Thank you very much for that. Even my talk is also not going to be for long. It's just a sharing of thoughts. When I said startup, in the sense of startups, what we are talking about, psychological medicine. Very specifically, I put psychological medicine for that. For some reason, I'll come to it later. Because it's printed as psychosocial medicine. It's not psychosocial medicine, it's a psychological medicine. Psychiatry also I didn't talk about it. Here, I don't think I'll talk about IAPP, private psychiatry and all things. Maybe later we can discuss. Maybe purely I'll limit myself to what exactly the startups. There's so much of a talk about startup in mental health. If you look into any of the newspapers, they say that there are almost 500 startups in mental health as on today in India. 500 startups, all the business ventures. What are they doing? This is actually after they are now in a pandemic, it's become much more and everybody is interested in that. First of all, if you ask me, what are your credentials to talk about startup? You're a clinician, we all know that, but why are you there? Maybe I can say that Chaitanya has left. Me and Chaitanya are shareholders of one startup. I don't know if any of you are also shareholders of any of the startups. I don't know about it. But me and Chaitanya. And I also happen to be a director of one startup. And that's why I'm taking a little bit of that liberty of even the topic also. I asked Chaitanya, this is the installation ceremony of IAPP. Why should there be a talk and all that? Then let it be a general one. And maybe once again I also say that I did a program of healthcare management in ISB sometime back. It's about 4-5 years back. It's a 1-year course, it's like a part-time course. Maybe that I'll put in front of you as maybe I have some credential to talk about startups. Nobody questioned, but still, it's a little bit of humility on my part to talk about it. Then I don't have any slides today. Maybe just a few points. When we talk about the startup as it is in the business sense, what is a startup? What does it offer? Why should something be called as a startup? Broadly, in the governmental sense, I say that any kind of a business thing which is less than 10 years. If it is more than 10 years, it will not be called a startup. And its turnover should be less than 100 crores. These are the two important criteria if you have to be recognized by the government of India to be a startup. Less than 10 years and it should be less than 100 crores. Then what is supposed to be offering? Startups, I think it's a very nice definition. Actually, I got attracted to that and that's why I thought, okay, let me share. A startup is a small company which is supposed to deliver a unique product. This product can be an innovation or can be an improvement. It need not be always an innovation, but it can be an improvement. Unique product, unique service or a unique business model. A product, service or business model which has to be unique. They are not going to copy from somebody else and it's not going to be something which they have taken from others. It has to be something of its own. And then what should it do? They create such a kind of a service which is irresistible to the group, public. They cannot resist it, they cannot avoid it. That's a kind of a product they are going to deliver. And it has to be like a revolutionizing people's lives and transforming the economies. So look at it, it's very nicely. A unique product or unique service which people have to find irresistible and irreplaceable. And then it is going to revolutionize people's lives and transform the economies. This is the title, this is the definition of a startup. It's very wonderful, it's like that. Then most of the times it comes with a kind of a disruptive innovation. I think we all talk about, we know about disruptive innovation. Disruption, when talk about, it's more of a constructive disruption. It's not a destructive disruption. I think we have to understand that. And somebody may ask, you're given 1, 2, 3 for very lovely, fantastic things, unique product and service, and then and irresistible, irreplaceable, revolutionizing lives and then transforming the economy. Can you give me one example? Can I say the first example is the reading glasses. Whenever it happened, this is a product. Maybe 100 years back, 150 years back, somebody of my age, my son or grandson would have been telling, అరే ముసలోడాకలు కూర్చోరా, ఎందుకు ఊరికే అక్కడిక్కడ తిరుగుతావు, గుడి కళ్ళు కనిపించవు, కింద పడతావు, ఆ బొక్కలు ఎరగొట్టుకుంటావు, ఎందుకు కూర్చో అక్కడ. That would have been. Because obviously after 60, 70, your eyesight goes. This made a kind of a difference which we don't realize. This is a disruptive or constructive innovation. Glasses made a huge difference. Does it satisfy all the criteria? A product or a service, irresistible, irreplaceable, revolutionize people's lives, and obviously, in your wisdom, transforming the economy. That's a simple thing like that. Maybe a lot of other examples come to my mind. A toothbrush. I feel that it's quite a bit of an innovation. And if I can extend to that a little bit, one of the fantastic disruptive innovation which has come, innovation, I look at it as a fire. In the human history, if you look at that, fire was one of the innovations which made a huge difference. Fire is what Yuval Noah Harari calls, fire gave Homo sapiens the power. Till then, hunter-gatherers and the nomads which were going around, and suddenly when they invented fire, the first thing they did is that till yesterday they were eating raw meat and tubers and then all the fruits and whatever the vegetables, they started cooking. It made a huge difference. Now you talk about so much of cuisines. It's all on the fire. Number one, it changed dietary habits. Number two, the fire, cooking, it helped them. Cooking kills a lot of parasites, a lot of germs and all things. So automatically the health has improved. And the third is, it's a big protection for the native humans from the wild animals. They used to set a fire around, collect the firewood from the forest and set a fire around and then sleep in the middle so that none of the animals will touch them. They protect themselves. See, the simple thing like striking one stone with the other, which is nobody would have, that's a kind of an innovation. Fire, it gave the human being the power. That's what he says there. Now looking at it, they changed the whole human history. And then, I talked about the historical things. Now we come to it. I think everybody knows Google. What Google made. Those Stanford dropouts, Larry Page and Sergey Brin, they just didn't want anything. They just wanted to give the public a good search engine. What disruption it made. Then you look at mobiles. Now, when I came to Hyderabad, that was in '88, I went to the telephone department there in the Abits for a telephone connection. They said yours is going to be 16 years because you're a doctor, it's 11 years waiting list. And the mobile cameras, where is Kodak now? These are all disruptive innovations because I gave a very grand definition of the startup, saying that unique product and then service and then transforming lives, revolutionizing lives, and then irresistible and replaceable. I think all these things fit into this. 1, 2, 3, 4, 5, 6, 7. That is the beauty of the startup and then disruption and then innovation. Now, what does it have to do with psychiatry here? That's what's going to be the important thing here. Does it have any relevance? It may not be exactly that, but when it comes to psychiatry, maybe next in a few lines, few minutes, I'll just go through historically in psychiatry, whatever has happened. Let's see that. If you look at the history of psychiatry, for a long time, almost for centuries, it was in the, we don't know what happened 16th, 17th century before for millennia, but the recent what we know is asylums. Asylum, that's where the first psychiatric care and it started. Asylums, it's literally like people are there living dead. Asylums really failed the patient, failed the relatives, failed the society, it didn't do anything. But it continued, there's no other choice like that. But when you go back and look at the last century, 20th century, I feel the 20th century has made a huge, you call it a disruption, huge events in psychiatry. The first half of 20th century, if you look at it, that's Sigmund Freud. Sigmund Freud's contribution is huge. What I say is that, none of us may be great in favor of Sigmund Freud, today's psychoanalysis and all, but Freud brought psychiatry out of asylums, but he drowned it in the unconscious mind. But that time, that was the thing which was prevalent, and then there's no other, technologically there's no advance. But Freud completely brought it out and said that the whole thing is because of unconsciousness and anxiety and all things. Around the same time, the first half of the 20th century, some other thing also happened. I think all of us, the neuromodulation, the whole thing is about, I'm trying to come to neuromodulation because now I'm doing that neuromodulation, now slowly directed to that. First half of the 20th century, neuromodulation has appeared for the first time. We all know about psychosurgery, Igor Moniz, 1930s. He got a Nobel Prize. That's an invasive neuromodulation. I think all of us know. At the same time, within a decade, Serlete and Binney, electroconvulsive therapy. It's once again a neuromodulation. It's a non-invasive neuromodulation. That's an invasive neuromodulation. Neuromodulation has its roots almost about a century before. But it didn't take off. ECT we are continuing, but psychosurgery, what people say is that any scientific advance has limitations with the technological, an advance at that particular point of time. If the technology has not developed, the scientific idea stays there. Maybe that's the reason. Psychosurgery time, there's not even a CT scan, fMRI, MRIs and all things, so it stood there itself. And unfortunately, another thing also happened to psychosurgery. One of the surgeons, Dr. Freeman, he did psychosurgery on none other than Rosemary Kennedy, who happened to be the sister of John F. Kennedy. And it was a disastrous result. The lady became lifelong disability. So that closed almost a chapter for psychosurgery. Sometimes the innovations, whatever happens, it gets closed there because of sometimes we overdo things or sometimes unfortunate happenings like that. But there is nothing technologically to support that. That's in the first half of the 20th century. Suddenly from asylums, neuromodulation was there. Then coming to the second half of 20th century, predominantly pharmacotherapy. 50s, chlorpromazine and then imipramine. Suppose I say chlorpromazine was a disruptive innovation. How many of you? We don't think about it. We think that, okay, another drug, but it was a disruptive innovation. It did a huge thing to psychiatry. It reduces the inpatient days from the asylum so much. It facilitated discharges. You go back and look into the CTP comprehensive textbook. The deaths due to exhaustion in the asylums drastically dropped by 90% after introduction of chlorpromazine. That is a kind of, we don't talk about this kind of disruptive innovations and all, but these are the things which are happening in every field. Look back, that was that. May not be. It will be imipramine and chlorpromazine. In addition to that, I put SSRIs. May not be pharmacotherapy, it may not be, but for me, SSRIs, especially Prozac, is very close to my heart. The way chlorpromazine has changed, it's a game changer. I look at Prozac also, fluoxetine also a game changer. For the first time in the history of psychiatry, we had a drug which you can give in the morning, non-sedating, working good, very minimal side effects. For the first time, it changed the way we look at depression and the way the treatment of depression has gone, SSRIs and especially the Prozac. But it may not be. Look at it very strictly, it may not go to the level of chlorpromazine, but almost there. So that's the second half of the 20th century. Now, we didn't look at the history like that, but you look at it broadly, see change what happened in psychiatry. This is all the efforts of somebody somewhere sitting there. That time they are not talking about startups and all those things, disruptive innovations, but these are the things which we look at it. Freud, neuromodulation, invasive, neuroinvasive, Igor Moniz, and then Binney, ECT, then chlorpromazine, then SSRIs. Now currently, 21st century, once again neuromodulation is revisited in the form of TMS. That time what we did was a convulsive neuromodulation. What we are doing is that non-convulsive neuromodulation. That time we had to put so much of electricity into the brain. But now we are converting electrical into magnetic and then again electric. So the impact, the cognitive deficits are significantly reduced. That's a technological advance what happens here. And 21st century, if you look at it in the last few years, I consider telepsychiatry is another disruptive innovation. This has happened with World Wide Web, the digitalization all over what's happening around us. These are all the things which we look at it, it's a huge changes. Telepsychiatry for me is again one thing which is going to make a huge change in the management, the way we manage the patients in psychiatry. This is another kind of an innovation. If you look at the historically, So many things have happened. Are we taking how much of advantage of it, and then how much of a thinking process in that line is it going? That's why I said that startup in in psychological medicine. Let's say look at it historically, that's what we don't know another 10 years or 20 years what's going to happen. Now after that, quickly I'll come to it. Now I told you that there's so much of a talk after in COVID and all that. Mental health has become one of the very important topics. Every TV person, every newspaper, everywhere talk about it. And as I told you, there are almost about 500 mental health startups. It's nice, for a politician or for a bureaucrat to look at it and then, oh God, there's so much of an explosion happening in the management of mental health. It's nice. Every business graduate, IIM, MBA, they look at mental health as one of the important area where they have to start and do something about it. But when I looked at it, most of them, and there are names there are a lot of funny names and all that. But the entire focus is on psychotherapy and counselling. Psychotherapy and counselling. That's where they talk about, let's say, mental health. That's why very specifically I talked about startups in psychological medicine. For an average layperson or anybody in the power, it looks like mental health, there's an explosion, so much of it's happening. But they're doing something good. I was looking at that some of the startups, they offer counseling, psychotherapy, 500 rupees per session. There is one of the startups, first 5 sessions are free. They don't charge anything. After that it's 500, it's 450. Do we support it? Somebody is, no. I think somebody like Dr. Chaudhary is saying no. Why?
No, who are we to stop it?
No, we are we to stop it. But the thing is that this is what? See, the point here is that they are offering that. But we say that if they are offering at 500, what is the quality? What is it in training the person, whoever the psychotherapist had that. But when it comes to me, I charge 2,500. And then you blame me saying that you charge so much that people cannot afford. You're putting yourself somewhere there, people cannot afford. When somebody else charges 500, we say that they may not be qualified. You can't get everything like that. But that is what. But more than that, I see a little bit of problem in this, saying that whether talking about when so many startups coming out and saying that mental health, we offer counseling services for everything, sometimes whether it does some kind of a harm to the psychological medicine as a specialty of medicine. That's why I just wanted to talk about it. It's a very simple thing. I just went round and round and round. For everything therapy, for everything counseling, for everything we do that. Sometimes whether they extend it to even bipolar and then depression and then schizophrenia, and that's not I don't know about it, but that can be a danger. Mental health can be managed like that. So unless it comes from a psychiatrist, this is one of the reasons why people talk about it, is that even now, people may not talk about schizophrenic mothers, but people still talk about childhood sexual abuse being one of the important factors in the development of schizophrenia and all. I think this is what in the general public they feel, and that's why they're going for that. So if somebody has to start a startup or a kind of institution for the persons to can provide service in psychological medicine, maybe it has to come from a psychiatrist. I don't know, maybe somebody like Dr. Pramod Kumar can start and think about it, but may not be every one of us. But I think unless you have the professional background or at least one of the advisors, because the core of psychiatry, the entire mortality is completely sidelined by these startups. It's not that they don't want to, they don't know. So is it time that one of us seriously think about it and then start on that? And then what is there extra happened? See, when talk about asylums, there's a huge talk about we have to deinstitutionalize. And that has become a very fancy thing for almost maybe a few decades, that community care, deinstitutionalize, almost like it's saying that these two are opposite things. Either you have this or institutionalize. But I think time has come, once again, we need to have the institutions. What people talk about, re-institutionalization. We need hospitals. We need acute care hospitals to manage the patients. But it has to be in a separate process like that. One is that have the hospitals, and from there it's going to be a rehabilitation step down service, not directly into the community care. That's where a huge gap is coming up. You keep the patient for 10 days here, but then straight away leaving into the community care, there's going to be a gap, there's going to be a lot of education process, they don't understand the process, that's why there's going to be re-institutionalization and then rehabilitation step down and then community care. This is the process which has to. Then who is going to take it? And then before I go into the digital thing, these are the questions which I keep bothering me. A lot of times, like, did we remain stagnant? But now, like just now you told about, okay, right, there's so much of 20th century, there's so much of advance and all things. 40 years back, when I was a student in one of the colleges, when I did my post-graduation, admission, patient has to stay in the hospital for 6 weeks. That's a standard. It's one of the prime institutions. I went the last 6 months back. They still follow the same thing. If you have to get admitted, you have to be there for 6 weeks. If you are not willing to stay for 6 weeks, you are gone. How many of us agree with that? Let me put it here that when I talk about this, psychiatrists come in that 6 weeks of admission, at least I'll talk about my hospital. Asha hospital average, we keep looking at what is average duration of stay. 10 days. 10 to 12 days average. Are they doing better? Are we doing better? What are the metrics? Psychoanalysis and all things, there are no metrics. But now what we talk about is 30-day readmission can be looked at as a metric. Was there any study? I don't know. Maybe Vijay should know, or somebody else knows. Is there any study comparing that? There's an institution where they are doing 4 to 6 weeks of admission, other institution doing 10 to 15 days of admission. Compare these two. Comparative trial where 30-day readmission, which is a metric. If it is not more in 10 days, why should we keep the patient for 6 weeks? We need to change. I repeatedly keep talking about, last time also when I was talking about neuromodulation, then accelerated protocols I was talking about. When I was a student, when a patient had a myocardial infarction, I still remember my physician professor saying that, don't move. MI, 3 weeks, bed rest. Except to the washroom, you are not going anywhere. I still remember very vividly my physician professor saying that idiot fellow, I told him not to move. He got up and then went to shave. Why should he shave? He had got a recently heart attack. Who is going to look at him, went to shave and then collapsed? That was 30 years back. Now today, I have an MI, I go there for stent and then CAB there, and tomorrow, day after tomorrow, they'll kick me out of the hospital. They'll get out of the hospital. You're not going to be here, and get out and then start walking and then doing and then go for rehab. Does it make a huge change in the quality of life of the patient? I had a fracture 30 years back. 8 weeks or 12 weeks, take a bed rest. Now I go there, they put plates and nails, and then third day they say, get out. Start a little bit of walking, you can go to office. Make a change in the quality of life. Are we doing this in psychiatry? Why are we still continuing to talk about long term and then long term and long term? I was calculating psychoanalysis. Psychoanalysis, I think all of you know that every week one session. Session actually at least about 45 minutes. Every week. For 5 years is the average time for any patient to go for psychoanalysis, which I looked at and calculated. It is 11,500 minutes. For the patient to go with psychoanalysis, Freud or whoever does psychoanalysis, 11,500 minutes of psychotherapy has to go. At the end of it, what happens? Freud now talk about symptomatic thing. He talked about personal growth. What are the metrics? God knows. Today, short-term CBT has come, it's cut it down to 1400 minutes, 16 sessions, weekly sessions, each session 45. Is there any comparison that those people who underwent 11,000 minutes and now who has gone 1400 minutes, is there any change? Was it better? If it is better, I'll not compromise. Definitely no. If it is not that, are we doing it right? Psychiatry is one area where we say that no, it has to be, it has to be, it has to be. One of my reasons where I was talking more and more about bipolar thing is that the reason, like last time I said that it's always like that. Somebody at the age of 16 diagnosed as bipolar disorder and he says more stabilization for life. Are you looking at anything beyond that? When rest of the other medicine, now there are no metrics also. As I told, a 30-day readmission. I think CABG, I think most of you know, CABG, the metric is that 100-day readmission. 100-day admission in the hospital with a cardiac event, that is a metric for CABG. I heard once, like Devi Shetty talking about Narayan Hudale saying that all our institutions in India meet the standard and almost none of them are inferior to any of the Western clinics. Now we have metrics, Y-box, HAMD, they are not the perfect, they are not the ultimate, but there is some metric for us to judge. Why we don't do that? Why we don't think about it? Why is the same institute, which is one of the prime institute, the premier institute, academic institute, not thinking about changing the admission time from 6 weeks to at least 3 weeks? Where are we stuck? You talk to them. If suppose you say that you are doing nonsense in Asha hospital, leaving the patient after 10 days, patient needs 6 weeks of time. You people don't understand that that's exactly the answer I'm going to get. Unless I have a study and something showing up. But this kind of a thinking about, can we make our treatments a little bit shorter? Number one, early relief. At the end of it, all of us are selfish. At the end of this talk, maybe I have my own selfishness in that. Because I keep fighting about it. When I talk about some kind of, this is not now. As a student, my professor asked me, do you take ECT if you get MDD right now? I said yes. Why do you have to wait for the 8 weeks or not 12 weeks or something before we start something? Now, like, can we try some of these things? Unless it has got a serious side effects. That is where mental health startups, let's not get carried away by that. We need a startup which is going to look into the psychological medicine, the core problems of psychiatry. Unfortunately, we don't have any kind of a metrics. Biomarkers, we keep waiting for biomarkers. I don't think it's going to happen so easily. But technology is going to give us biomarkers. It's going to come. I am quite impressed by the digital phenotyping, digital footprints, social rhythm, metrics. I think all of your psychiatrists here, I should not be saying that, but when I go to the general public, I say that I have a mobile, there is an app, whatever name you give it, mental health app. It records my pattern. I generally sleep up to 5 o'clock in the morning. Average, I send about 10 to 20 messages. I talk to about 20-30 calls in a day. My average monthly expenditure is about 20,000. This is what is being recorded in my mobile app. And then my movements, the way I sleep, the way I send messages, the way I make calls, the way I receive calls, the amount of money I spend, the movements. This is there, the data. But for the last 10 days, MS Reddy, you're waking up at 3 o'clock. From 3 to 5, 100 messages are going out. But 200 calls every day. Last 15 days, generally when I go to a shop, I buy a shirt, with 1,000 rupees, I buy 1 or 2. Last time you did shopping, you bought 4 shirts, each of about 4,000. Your GPS, this shows that you've been moving around, your petrol bill has gone up. Last 15 days. I think all of us know that patient comes with a mania and says, I am alright doctor, why are you treating me? Show me, where is the proof? I am alright. And you talk about all those things and try to convince him. Suppose he has this app with him. Suppose he doesn't delete the app. The manics are very smart and they can delete the app. If they do, can I show him and then, sir, just have a look at it. I'm not saying that this is the proof. Last 15 days, there seems to be something slightly happening. You're waking up at 3 o'clock. Digital biomarker. I'm banking more and more on that rather than neurobiological biomarkers. They're not going to come. This is going to be diagnostic. And at the end of 2 months after your lithium or whatever treatment you give, it's going to set back to the pattern. I can show him the person the same thing. Look, this is it. This has happened. But again, this is your own mobile. I don't have any remote control on that. So far, my history shows that I never Googled how to commit suicide. Last few days, my GPS showed that morning 5 o'clock I am visiting Hussain Sagar few times. What's happening here? Suicidal thoughts and behavior. I think we all talk about predictors of suicide. We have a list of things. I never had much belief in that. I believe it's like 0.01% or 0.02% is the predictive value of that. Horribly low. Whatever the indicators we have. This particular app, it's showing a very significantly chances of suicide attempts are very high. Can we bank on that? What I talked about, digital phenotyping, markers, social rhythm metric, which is a simple thing which is going to be there in your mobile. Everybody has got mobiles. That's another disruptive, as I told, that innovation. This is going to be disruptive, this thing, for mental health, this thing. Can we take advantage of that? Can one of the startups, the startup can be Betak Chaudhary, he is going to, now I can actively look for an app which is going to give us this information and is going to, we are going to get that. And when we have a startup, when we talk about a psychiatric management facility, We are not looking at just giving counseling or something like that. We are going to incorporate all this. We are going to talk about all this. That's going to be a huge game changer for the benefit of patients with psychiatric illnesses, not these mental health apps. I'm afraid actually these mental health apps are actually putting it in the wrong direction. Everything okay, talk to somebody. No. One of the names of this startups is Psychiatry. Psychiatry, I said Psychiatry, T-A-L-K-I-A, I said Psychiatry. There are 500. So this is actually, these are the few things I just wanted to share with you, nothing more than that. So whatever happened, what is a startup, something like that, and then what exactly is that? And then what's happening, there's something. End of the day, just maybe another 2 minutes. Somehow I am very fond of, for a long time, almost 20 years. Can we do something to shorten the duration of treatment? Is there something where I can give a quick early response to the patient? Can I get him out of it a little bit faster? Lot of criticisms. Can I, a little bit faster? Can I show him something? Now, like whenever any of the pharma representatives ask me, tell me 3 wish list. I wanted an antidepressant which works in a week. Second, third, same thing. Antidepressant which works in a week. Huge difference. It's okay 3 weeks. No sir, it's not okay 3 weeks. I don't have tools now. 1 week change in the patient's psychiatric condition, whether it is depression or psychosis or mania or whatever it is, it has got a huge ripple effect. For the first time starts feeling that I'm going to become better. There's a hope for the patient, hope for the family, hope for the relative. Ask him for 3 weeks, it's not going to be. So that's where it is. This is where sometimes there will be a risk. When you talk about the startup, there's going to be a risk. Unlike innovation, technology it has to use, but any startup has to be scalability, has to be there. Otherwise it doesn't work out. There's a huge risk. But is there any kind of an intervention where we can make it? Possibilities. Now, like some of these things may sound ridiculous today, but at the same time, we have to look at the risk benefit also in medicine. We can't talk like a mental health startup, like we can't just push ECT for every patient like that. But if something is safe, something is showing the results, can we do it? And then, a lot of times, like people say that even a physician, it's okay, the depression was. I think all of us know. The risk of cardiometabolic in patients with mental illness is twice compared to general population. And when you look at pharmacoeconomics, they talk about simple because of depression being untreated or lately treated, the cost is $1 trillion. I calculated that 1,000, a million, how many millions and how many billions and all things. If you convert into rupees, my God, it's like 80 lakh crores. There's a study which showed in the Psychiatric Clinics of North America, having a psychiatric service in the corporate setup drastically improved their productivity. So whether we have to look at these are the other things also. That's why I said that startup may not be a right term, but I thought private psychiatry may be a correct forum for me to talk about it. Private psychiatrists deliver 80% of psychiatric care in India. Private psychiatrists can be entrepreneurs. There you can start. Unfortunately, most of the young psychiatrists don't even want to come anywhere near starting a hospital or anywhere. They have their own reasons. I didn't talk about MHCA at all because I didn't want to touch about that thing. Right? Because these are the one single definite thing will be how soon I can get a patient symptomatically. How soon I can get them out of this morbidity, or how much morbidity I can reduce and then duration of it, which if you can do, when you have a startup in that and the kind of idea about that, that's going to make a lot of difference. These are broadly the things I just wanted to share with you. That's why as I told that it's not an academic talk, it's just thinking loud and nothing more than that. Thank you very much.